Okay, should be able to just toggle through. Great.
It'll let you do, it's
I can
recorded.
use the, oh, I can use this to advance them.
Yeah, I'm gonna say if you wanted a different view, do you need like?
Oh, no, I just want to be able to
I just hit
advance them.
enter, I think, and it went, or not.
Or is it one of these?
Oh, it just did it. Oh, the arrow worked.
Oh, those, okay, I was using, yeah, okay, great.
Okay.
Makes me okay. Let's stay on this side. Okay, hi, good morning. My name is Marie. I'm one of the nurse practitioners that works with otolaryngology, head and neck surgery, so OBH, primary service. So we basically do a lot of oral cavity or, pharyngeal cavity cancer resection with reflex. And one of common things that we'll have are patients who have tracheostomy or laryngectomy following the surgery. And this often comes up, throughout healthcare. Nurses, physicians, we even have consulting physicians that, kind of universally just say everybody has a trach and things like that. So it's not exclusive to nursing, regarding what is the distinction of this. So you're not alone in this confusion. So the point of this lecture will just to be kind of differentiate between those. And feel free to stop at any time, answer questions, shout out questions is fine. We can be very informal. So objectives, we're going to talk about the basic anatomical structures in the head and neck area and talk about, what causes airway compromise and, what's involved in an emergency airway procedures and postoperative care for both tracheostomy and laryngectomy. They're similar, but there's a couple differences, as well as the ventilation differences between the two. And then basic principles of speech. Regarding that with options, because sometimes patients will ask you those kind of questions too. So our basic anatomy of the mouth and then the neck. So just an anterior view of the mouth, you have the soft palate, the wall of the pharynx, and then the tonsil pillars at the back, as well as the base of the tongue. And then on the side view, you can see that the head and neck area is kind of divided into three different areas. You have the nasopharynx, which has a hard and soft palate, and the nasal cavity, and then the oral pharynx, which comprises the tongue and the tonsils, and the laryngopharynx, which has a epiglottis, the cords, thyroid cartilage, and then below that is like the hypopharynx, which is the esophagus, trachea, and thyroid glands. Oops. Okay, so lots of reasons why there's airway compromise that can lead to these laryngectomies and tracheostomies. The most common that we see is a physical obstruction, whether it's a tumor that's invading the airway, stenosis of the tracheal wall, related to, perhaps somebody's been intubated for a long time, developed some tracheal stenosis, swelling. You might see like an ER, the angioedema, anaphylactic reactions, and clots, bleeding. Vocal cord paralysis can also attribute to airway compromise as well, because the vocal cords aren't functioning as they should. Oversedation, so patients not, their ability to take a deep breath is altered due to sedation. Any congenital anatomical defects that you would see. We don't see too much of that. And then any kind of trauma, mechanical injury, motor vehicle accident, strangulation, things like that, or burns to the airway, which would really kind of contribute to swelling, and a lot of radiation therapy side effects that we see quite a bit of. Bleeding can also obviously compromise the airway, and any kind of infection, which like epiglottitis, don't see that too much anymore, thankfully. So the physical signs would be any stridor or streeter, so that's kind of like where wheezing is happening either above or below the glottis, gurgling noises, altered breathing position. Patients that you might see this like in COPD patients where they're like 3-point position breathing, kind of leaning forward to kind of optimize their breathing. These patients will just, kind of be sitting very much upright, not tolerating laying flat at all. The tachypnic as well as hypoxic. You've probably seen all these as well. Accessory muscle use, sternal retraction, probably not too much nasal flaring, but basically using accessory muscles like you'd see with like a COPD patient or what's it called, asthmatic patient, asthmaticus. And then also they just get very tired. It takes a lot of effort to, maintain this effective breathing. And it's just, they're using a lot of, accessory muscle use and they're focused on it. So they can easily tire out. And it usually is not very dramatic, like, and then boom, it can just be very subtle, like just quiet breathing. And you think, oh, they've settled down, but then they'll just stop breathing. So it's a little different than what you might expect. So how do we manage our airway compromise? So we want to kind of reverse any causative factors and, identify those. So, if it's a patient like a COPD patient that, is too much oxygen and knocks out their drive, looking at that, or, looking at, maybe some sedative effects, maybe their anesthesia is not quite reversed, things like that, position changes. So also, raising their head, doing the head tilt chin lift can be helpful as well. And then providing oxygen and ventilation as needed if you need to bag them versus providing more oxygen if they're hypoxic. If they have airway edema, we'll do the racemic epinephrine for that, and then also steroids as well to reduce edema. So usually the majority of the time, these initial measures can be helpful, but if they don't, then we have to start looking at mechanical ways of managing their airway and perhaps doing an LMA or intubation. We're kind of at this point, obviously want to get the surgeons involved, because of, usually a surgical airway. So we want to, hopefully these above measures will help, kind of want to avoid doing an LMA if, without the surgeons being involved. So we're not making things any worse. And then sometimes we have to just consider an emergent surgical airway if we're unsuccessful there. So we have different types of surgical airways. We have planned ones, which are the ones that we like, right? So we have, they're consented, we get everything, we anticipate they're going to be having an airway put in. And if we can, we'd like to perform the trach with them awake, doing like a local anesthetic, and then do sedation once the tube is in place, versus a sedated trach, which would kind of be more like your traditional patients are coming in for like a major surgery, and we'll take them back to the OR, and once we put them to sleep, then we'll start making the incision and create the airway. Unfortunately, sometimes we have to do an emergent slash trach is like the unofficial term, but it's basically cricoid thyroidectomy. We want to avoid those at last if we can, but we've had them, we've done them, and that's it's not ideally formalized, but if we need to get an airway, that's what we need to do. And that's if we've been unable to intubate them through the nasal airway or oral route. And we've done them in the ED at the bedside, even up on the floor at times. I don't know if we've done one in PACU or not, possibly. So we like to avoid those, but they have been done for sure.
Okay, great.
They'll do them back in the OR. They won't usually do it in PACU, but we've taken patients back to the OR, and then before we're formally putting them, under general anesthesia, we'll have them awake. I mean, they're relaxed, but they're not fully anesthetized. So there's times that we've done those as well. You might see it on the OR, I don't know on the consent, but maybe on the boarding, or yeah, you might see it on the boarding for, like, I'll say awake trach, or even under the airway notes. Let's see. So this is an algorithm that American Society of Anesthesiology uses in terms of, kind of the methods that you go through with doing awake intubation versus intubating after you induce with, propofol, and then assessing using face mask and if that ventilation is effective or not, non-emergent versus emergent, pathways. Go through that. Indication. So tracheostomies can be done for a lot of different reasons. If you've been up in the ICU or worked in the ER, you might have come across patients who are, been on a ventilator for a long time, especially with COVID. We've kind of seen a lot of that. They're orally intubated or nasally intubated, unable to wean from the vent. So in order to assist with weaning or just to have a more permanent way to ventilate them, perhaps a patient with like, neural fracture, quadriplegia kind of thing like that, who has like C2, C1 compromise. We would do a tracheostomy because you're definitely, you're bypassing all here and getting much quicker access to the trachea. Also, if there's any kind of airway obstruction or tumor, which is the majority of our patients, they have a cancer on their tongue or a base of tongue, and we need to do a resection, and we know that this flap is going to be very large and will prevent their ability to breathe, so we will put a trach in, kind of planned with their free flaps. Infection or anaphylaxis, so patients, sometimes you see the Ludwig's angina or any kind of anaphylactic reaction to medication, and it'll cause angioedema to the point that they're swelling and you're not able to intubate. We've had to do that. Vocal cord paralysis, as we had talked about before, and congenital abnormalities. Some patients in the effort, like perhaps they're in the ICU for a long time, been ventilated, pneumonia or COVID or whatnot, doing a trach will just be much easier for pulmonary toileting, managing secretions, and being able to have a trach is just much more effective. And of course, major head and neck surgery that we talked about, laryngeal trauma, that sometimes can just be managed with a trach temporarily until the larynx can be repaired. It doesn't necessarily have to be a laryngectomy, but sometimes a tracheostomy will be effective enough at that time. Or the traumatic brain and spinal cord injuries that we talked about, a minute ago, where the diaphragm is not functioning well because of that spinal cord injury. Oops, I keep pushing the wrong arrow there. There we go. Is that right? Yeah. Okay, and this is just a little bit of anatomy here, seeing how the different muscles and layers necessary to go through to reach the trachea. So you've got your, we do a vertical incision initially, and then can do a horizontal incision across between the second and third ring of the trachea, and just kind of, how we're going through the isthmus and identifying, important structures to identify the thyroid and the cricoid, and identifying nerves and things to avoid damage to them. Okay, complications from tracheostomy. So in the interim period would be a loss of voice. And I always kind of reassure patients, and I'm sure you've seen this as well, that, when a patient gets a trach and it's, just because we've done surgery up here and we've just done it to, manage their airway, a lot of people panic and think because they can't talk, it means their voice box is gone. So I always try to reassure patients, and I'm sure you do as well, your voice box, this is with a trach, is still there. We're just, we're not using it right now because of all the swelling. It's compromised, but we will have that back. And definitely if the cuff is inflated on the trach, which is probably what you'll see, you're definitely not going to hear any voice at all because there's no air that's going to be going past the voice box because of the cuff being inflated. So obviously patients can wake up agitated and panicked because they can't talk, which is real stress, and breathing through your neck. I often tell patients, a lot of people panic because the way I explain to our patients is, you came into the world breathing through your nose and your mouth, and that's what you're used to for these 40 or 50 years you've been on earth. And when you wake up from surgery, you're not able to breathe through your nose and your mouth. You're breathing only through your trach. So that can be just really distressing because that's what you used to do, is breathe through your nose and your mouth. So what I usually tell people and families as well is, if having them put their hand in front of their trach, not on it, but just in front of it, and taking a deep breath and exhale, and they'll feel that air moving, and touching their fingers. So that can kind of mentally reassure them, because their brain is still kind of thinking, I'm breathing through my nose and my mouth, and now I can't. And you have a neck wrap on, and you're swollen. So kind of giving them that physical reassurance that, I'm feeling air, I am breathing, can be helpful with patients that are really, distressed over that. Having a trach can cause some delays with speech and language. If it was put in, on a pediatric patient or an infant, then, definitely it would. For our patients, their speech can be affected even after we've changed the trach, deflated the cuff, removed the trach. Sometimes there can be, ongoing issues with speech, but our speech therapists work with them as long as necessary. Temporarily, they can have a loss of smell and taste, especially if we've done some reconstruction on their tongue, and that will come back over time. But it probably won't be as, won't be the exact way it was before surgery. So, and then compromised nutritional status. Some patients are limited in what their oral intake could be after a tracheotomy, whether they have an oral diet or using enteral nutrition. Some of our patients, if we've just done a trach for them and they're able to swallow, then we allow them to swallow. If it's just a trach, if we're doing like a free flap reconstruction, we're not having them eat or drink because that's affecting the surgical site as well. So, and of course, they'll have issues with swallowing and can have a risk of aspiration, which is why, we have SLP, see our patients while they're in the hospital, and then they follow them ongoing in the clinic too, to get them back to hopefully, an optimal oral diet. Secretion control impairment. Yeah, there can be issues with if the trach if you're not able to manage your secretions very well, that could be related to maybe improper size of the trach. If it's not big enough, maybe it's not long enough, it might be difficult to effectively get all the secretions removed. But we can kind of optimize that as well. And then when you have, I don't know how much you lose PEEP and stuff and poor oxygenation, I'm not really quite sure about this comment, but with the trach, that would be kind of like a lot of long-term things. And that, again, that might be just related to placement. Let's see if you have a cuff failure or something like that. But for the most part, usually your ability to use PEEP is enhanced with trach. So what's our trach care in the immediate postoperative period? So we'll get a chest x-ray to confirm placement and to rule out any pneumothorax. We'll want to evaluate for any kind of crepitus, palpating for subcutaneous emphysema, which could signify, some air that's escaped from the trachea into the neck, or any tracheal deviation. There might already be some tracheal deviation just due to like the type of cancer the patient has and what kind of surgery. So sometimes it will be deviated, but it's normal for that particular patient. So if you are concerned when you're doing your immediate assessment of a patient, when you receive them in PACU, if the trach appears deviated, you want to kind of confirm with the resident, if that's within that patient's baseline or not expected. When we put in trachs, we'll suture the trach plate to the skin so it doesn't come out. Trach ties can get loosened or get pulled out. Patients, I've not had a patient pull out a sutured trach before. Usually, but with trach ties, they certainly can, but the suture will help. And because we just don't want any manipulation of that trach when it's fresh. The track isn't established. We'll always have the cuff inflated when they come out of the OR because, until they're really fully recovered from anesthesia, so they can manage their secretions. If we deflated the cuff right away, there could be a lot of bleeding that the patient isn't able to cough out because they're still, under sedation. So we keep the cuff inflated. We usually just inflate it to so the pilot balloon feels like a soft grate. We don't want it like airtight, like a tight balloon or anything, because it just puts too much pressure on the walls of the trachea. And then we'll want to do scheduled NPRN lavage and suctioning. And I know this is a hard concept for me because I had worked in ICU for a long time before I transitioned. And, I was very much used to people with like this long, well-established trachs and who are vent dependent, things like that. And so we would minimize a lot of suctioning to avoid trauma and irritation. And so that was a hard concept for me to, suction every 2 hours schedule. That just, it just seemed very contraindicated from what I was used to. But with a fresh airway, you're going to have a lot of blood. You're going to have a lot of swelling. And if we cause an airway obstruction, if the airway is obstructed because of blood, definitely will cause, compromise, won't be able to breathe. A lot of problems. So scheduling lavage and suctioning and as needed is important for these new trachs. Frequent suctioning, obviously, to maintain airways. I said we want to avoid accidental decannulation. So sutures should be pretty intact. They don't really start to loosen unless they're in for like 7 days or so. We usually change trachs between day 3 and day 5 post-op, and they've always been really well secured. So you shouldn't have an issue with that. Unless maybe you're taking a patient that's coming down to you from inpatient side who they were sutured and hadn't changed it yet, that might be an issue, but a fresh one from the OR, it should be fine. Using humidified air to prevent plug formation, that's important as well, and we can get into that in the next slide or two. We don't want to change the trach or the trach ties on a fresh trach at all. So I would, you want to assume, especially again, if you're getting a patient from inpatient side, or maybe they came from home with a trach, you just always kind of want to double check that. I would assume that you're not going to change the trach or the ties. I would always assume that until it's clarified with the team. And then, like I said, we changed the trach around post-op day 5. That gives between 3 and 5, because we want to wait for that track to be well established. If we take it out too soon and the trach isn't well established, it can be very difficult to put a new trach in, and that could lead to like a false passage. And then, of course, educating the patient and their family members, which I know that's pretty difficult for you guys to do, because most of your patients are being admitted. I don't think you're doing, maybe we might do a trach change and they're outpatient, but I would think any fresh trach, they're going to be admitted. So you're probably not doing too much education, maybe just some little reassurance kind of things. If it is established their trach and you've determined that with the team, then trach ties can be changed, as needed, but you always want to make sure you're maintaining support of the trach as you're changing the ties, so as not to risk false passage. So lots of different types of trach tubes. I'm sure that you've seen coming down here. We have the cuffed trachs, which I kind of tell the patients it's kind of like having a blood pressure cuff on the trach, and it's just deflated, but we can inflate it as needed. Patients who are on a ventilator will need a cuffed trach, so the air is going into the trachea, not up through the mouth. And it also helps reduce the risk of any blood above the trach from coming down into the lungs, and prevents aspiration in that way. Cuffless trachs are ones that we use when we downsize a patient to in the hopes of eventually removing the trach. So we'll switch to a cuffless around day 3 or 5. Some patients, you might have noticed over the past couple months, Dr. Castor's done this. Some patients who have maybe it's very mild minor surgery, like maybe a hemiglossectomy, it's a very small defect, and it doesn't anticipate too much swelling. He might just right off the bat put in a 4 cuffless right away, because he anticipates patient's going to be breathing well through their nose and mouth, and the trach is just kind of as a backup. So sometimes you might see someone come out with a 4 cuffless trach, but for the most part, usually it's a 6 cuffed with the cuff up. Fenestrated trachs are the trachs that have like a little hole here on the top of the outer cannula. We don't really use those that much because there's obviously a higher risk of aspiration, and there's actually risk of granuloma forming there, which can contribute to like tracheal stenosis. So we usually don't use the fenestrated ones. Non-fenestrated are the majority of the ones that we use, which don't have that opening there. And you can kind of see it a little bit better here on the picture. So this is the majority of the ones that we use here. We don't typically use a fenestrated trachs. Bivona trachs, you may have seen that once in a while. They're trachs they use a lot in the pediatric side, and we do use them at times as needed. They don't have an inner cannula, so they're a little tricky. They have a high risk of obstruction because there is no inner cannula to take out and routinely clean. You just have the one cannula. Metal trachs, we haven't used them as much as we used to. They're nice because they're much more low profile. They don't stick out as much, and they're more comfortable. They're stainless steel. They're just more comfortable for the patient. And they do have a removable inner cannula. And you can even cap them, but you can't hook up an ambu bag to them. We usually have to swap them out for a traditional Shiley. And you can't go to MRI with a metal trach because of the metal.
We had one come in last week. One of our nurses had one in Duncan that
Came in from home?
a patient came in from home, forgot the inner
Cannula.
cannula.
Oh, yikes.
So that patient ended up getting a whole new setup.
Right.
They ended up sending them home then with a new metal.
Oh, they probably found another one.
Found one.
Yeah.
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 But it was like one of those scenarios that like the guy just forgot that
Right.
it's at home. Or
Yeah. Yeah.
But we hadn't seen a metal one in a long time.
Yeah, we don't. Yeah, we used to use them a lot, but the problem was the patients would, we always tell them, I don't know why I bother writing discharge instructions because they're not really read by the patients, I think. I always tell them, put the obturator in with this portable suction. You know, so it's, you have, you know, because they usually will go, right? But who knows where they have it. So, right. So a lot of times they'll come into the clinic and they don't bring the obturator with them. So then you can't really use the trach because it doesn't have an obturator. You know, there's not a bunch of extra obturators laying around, which there were. And so that can be expensive. So we've kind of backed off on it. And then if they go to like a rehab, the rehabs don't like the metal trachs. So yeah, we haven't used them a lot because yeah, they're not bringing in the obturator. But yeah, that can be a definite struggle. The nurses on 4B, you know, are really knowledgeable about things as well. I mean, you can always, the residents can always fill you in on things too, but they're usually not as available. But you know, always kind of reaching out to 4B nurses that, you know, they're a good resource for things too. So yeah, so those are the trachs. And then now we have these new trachs, these shyly flexible ones, which they're a little bit different. Started doing them, I think last July, I want to say, or this past July, maybe July before, that we're using that have both reusable and disposable inner cannulas. And there's a lot of numbers and things on these trachs. I don't particularly like it because it's just confusing which numbers are which. But basically, see, there's a bigger blow up of it. You know, this is all this data about the diameter of the inner cannula, internal diameter, and then this is the internal diameter of the outer cannula, and it's, or the outer, actually the outer diameter of the tracheostomy tube itself. Just like way too many numbers for me. I mean, on bottom line, I want the down and dirty. So basically, in terms of, you know, you want a 6 cupped trach. You know, I don't look at these numbers. You know, I would be looking at this number because this here, I guess they labeled it called Jackson size. So when you say you want a 6 cupped trach, it should be 6, and then the C means it's cuffed tube. So I don't know why they have an N there versus an, so make it worse. They didn't ask us how to do this. So so this is an 8 cuff. So if we're looking for 6 cuff, 6 cuff. The N is really not significant. And then this has to do with some international standardization size, blah, 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 but it does match what this inner diameter is. But again, not important to us. Really, the most important thing is this cuff and what kind of cannula is it. So kind of the first two and the last are the most important in my book. H represents a disposable inner cannula. I mean, you can throw it out. I don't know why it's H. And then what if it was an R, then that would be one that's reusable. Now I haven't gotten the final. In the beginning, when we first, I haven't updated this yet, so I'm not quite sure what the update will be, but when this initially rolled out, we only were using the reusable because they didn't have stock of the disposable. Now I've seen a little bit of both, but I have had some of the residents are asking me, and I didn't really know the answer. You know, if you had a patient who was an R, meaning they're supposed to have a reusable inner cannula, but if they lost the reusable one, if whatever got thrown out in the linen, and all we had were the disposable, can you use them? And we have, and I don't know, you know, I haven't dug deep into the literature or the manufacturer's recommendations. I mean, I would think the only real difference, I mean, it can go in there. I think just maybe, you know, a reusable one is, you know, the material allows it to last longer. The diameter and the size, the length are not different. It's just maybe the materials can be used longer term and handle frequent suctioning or in and out versus disposable maybe is different, but I would think just do either one. But there's a lot of patients, you know, that have bad insurance and their insurance might not cover the disposable. They might only cover the reusable, you know, and I think that's why they're doing that. Or maybe on the immediate period, we're using the disposable because maybe we're changing it so much and things like that. I'm not quite sure what the difference is, but as far as I know, unofficially, they're interchangeable, the inner cannulas. I mean, it will go in, nothing bad's going to happen, but ideally, if this is a disposable inner cannula, you want to use disposable inner cannulas. If it's an R, you want to just use the reusable, but again, reusables have their way of disappearing. So basically what I would focus on is this, and this. So if it's uncuffed, it would be 8UN, and then you'd see for the H there. Especially when you go to order them. The funny part is when you order the trach or you ask the clerk to order them on a, I don't think I have it on here, but I took a picture of it because ordering the trachs was just really frustrating. See, I have saved it on my favorites. I should have added it to this. I can't remember stuff. Oh, here it is. So I don't know if you guys have seen this, sorry, it's very unofficial, but so if you go to get the box, not the big blue box, but the individual box of the trach, you might, like, this is a 4 cupless. So I might say to the clerk, okay, I need a 4 cupless trach, but what's the big number? Everybody sees is 6.5. And that's that outer diameter, blah, 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 useless information.
And the intercannula is different. You used to be able to ask for an 8 Shiley intercannula, you get 8 Shiley. Now it's,
Yeah,
they're different.
right.
It's very
Very complicated, yeah. So, the poor clerk in their mind, you say, okay, I need a 4 cupless trach. And they see the big number 6.5, and that's what I go to too, right? I go to the big number. But this is what you really are looking for. I know, nobody asked that today. So I kind of go by the reference number, this part, ignore the big number. And then, so this is what the 6.5 really means, 4 uncuffed reusable cannula.
So the reference number matches that little, the reference number of that.
No.
It was COVID and trades, yeah, and they got bought out by next time.
Well, and the problem is that people were trying to, like, I came from Toledo Hospital and we've had those for about a year.
Oh.
And the problem was that, again, with the intercannula, people would be like, oh, it's because,
I know.
And then they try to be shoving these 8.5 cannulas into these people.
Were they
Right.
growing up? Were they
And-
like,
I mean, they just don't go in because it's trying, you're going through that metal or
Yeah.
the plastic tubing, and it's like, I can't get it, and then these people with their first traits are like,
Right, yeah, it's ridiculous. So the bottom line,
Like you're stupid, like, oh, you don't know what you're doing?
yeah,
right,
and they're like,
yeah.
and most of them were on like ventilators and stuff, so like, they're like, oh my gosh.
Yeah.
Like,
Right, right, trusting us. So basically, that's kind of why I have this picture. That's why I would tell them, okay, order, you want to look at big numbers, fine. Sure, it's a 6.5, but what I really want for my purposes, I know it's ridiculous, but that's the bottom line. That's why I keep it on.
so are these like the first choice now, or do we still use the?
Majority of the time, I haven't seen the other ones. I mean, initially when they first rolled this out last July, I want to say it was July 21. We were still transitioning from the older ones, but this is what I've seen on the floors all the time.
Okay.
I don't know what you guys have seen. I can't remember an OR what's in there, but for the most part, I think this is,
I had somebody.
yeah. So what I kind of tell people is, ignore this, ignore this. This is where you want to be. This is going to tell you what you need to know. So, if it's reusable, if it's cuffed or not. I mean, you should be able to tell if it's cuffed because you're going to see the pilot there too. So bottom line, go for this little square, not this blah, blah stuff. It's just stuff to make us.
In our documentation, when we're.
Right, and it's going to be covered with secretions. They're not going to be able to read it anyway, right?
If
So,
we're still- Like, unless they identify that in report, they'll come out
Yeah.
and say like, oh, it's a cup Shiley, like they'll.
Yeah.
We'll document that
they'll
way.
say,
but if-
yeah, but it won't say, right, it'll
Yeah.
have 7.5 or, it'll say 7.5 as a 6, right? Like if it was a 6 cup, it would have this, right? Because a 4 would be, this would say 6.5 and this would say 4. So this is going to be probably 7.5 and this will say 6. So this is kind of where you want to be. But of course, like I said, we're going to avoid secretions and sutures, covering it up. And, yeah.
Oh, well, that's okay.
Yeah. Or I mean, you can go like this, like this.
Got it.
Yeah, very frustrating. Believe me, I was not happy about that. They don't ask us, right? Someone somewhere far away looks at all those things. Ooh, Toledo, there you go. Yeah. Yeah, there's so many cooks in the kitchen. So, and then these are just a little close up of, how to remove the inner cannula. You've probably already learned this already because we've had them. The old way, the disposable ones, remember it was like if this was the cannula, you'd have this little tab and you pinch it and you pull it out. That's how you did the disposable ones. The new one, and then the reusable, remember it was a screw in, right? You lined up the two circles and all that stuff. Those made so much sense. But these, both the reusable and the disposable, function the same way, which is good. But you're basically, just pinching those tabs and then pulling it out. So it's kind of works on the inside to hold it in place, where the traditional one, it was on the outside. Okay, so that's one difference, and that's okay. I'll give them that. Trying to be nice. So enough about those trachs. All right, laryngectomy. So laryngectomies can be done for a variety of reasons. Most times for cancer, we consider something a primary laryngectomy when they haven't had any other treatments for their cancer yet. So like, let's say someone with brand new, whatever, just newly diagnosed larynx cancer. And we've determined that surgery is the best option versus having chemoradiation. That's typically not what we do, but for whatever reason, sometimes we might do a primary right off the bat. It's never been treated before. First time we're treating it is surgically. So that would be considered a primary laryngectomy. But oftentimes we do a salvage where when the cancer is initially diagnosed, oftentimes we'll have the patient do chemoradiation because we want to preserve their voice box as much as possible. You don't want to just jump right to, if you can avoid it. So oftentimes the first treatment would be chemoradiation, immunotherapy, things like that. But then if the cancer recurs or it's persistent, things like that, metastasized, then we'll do a salvage laryngectomy, which means we're operating on an area that's already been treated in some way. So the tissue is not as healthy. And that's the majority of our patients, because a lot of hospitals don't do this option because it is just so complicated. Or if there's cancer at another site, like I said, base of tongue, and you've got metastasis, or it's spread to the hypopharynx and they're aspirating, then you might do a laryngectomy at that time. Or there might be a patient that maybe had cancer and it was successfully treated with chemoradiation, but their larynx is dysfunctional as a result. They're not able to swallow, they're aspirating, things like that. They're not managing any just normal saliva. Even if they were fed this way, they're still not managing secretions and things, and they need a laryngectomy for that reason. But the majority of them, in terms of what you'll see, is usually a salvage laryngectomy. So this picture I usually will show to patients a lot as well to kind of help them learn the difference. And basically, the biggest takeaway, and should do it a little bit better, but before you have a laryngectomy, air is going through your nose, down your pharynx, down into your windpipe, same with your mouth, back to the throat, down to your windpipe and your lungs. But when you have a laryngectomy, you've taken the windpipe and you've moved it forward. So it's no longer connected to the back of the nose and the mouth. I usually do that with patients. I'll have different colored pens and try to draw and get all crazy. But, kind of telling them that, usually your nose and your mouth, before a laryngectomy, you breathe through your nose and your mouth and it's going right down into the windpipe and your lungs. But once you do a laryngectomy, you're cutting off the bad stuff, reconstructing it, boom, boom. And then you're moving it forward. Here's the neck, here's the incision. And you actually, with the laryngectomy, you actually bring the larynx reconstructed forward to just like a stoma, kind of like, say, like a colostomy. Right? Colostomy, bring that. I never say that to patients, but but for my brain to figure it out, bring it to the surface. So because we're moving it, it's no longer connected here. Right here it was connected, but now we moved it. So because they're no longer connected, your nose and your mouth are not going to deliver any air to your lungs. The only way you're going to get air is through here. Not with a trach. Trach, we're just going like this. Incision, go in there, put the cannula in, right? But this, we're moving it. Because we're moving it, it's no longer connected up here. So the only way they're breathing is through their neck. So that's the biggest, and it's not reversible. So, and that's important for us to know because putting a nasal cannula here is not going to be effective. putting any kind of oxygen masks here is not going to be effective. This is where they're going to ventilate. This is where we're going to suction, things like that. So now both with trachs and laryngectomies, because they're breathing through their neck, trach is usually temporary, and with a trach, you are still moving some air here. But if a trach is uncapped, you have a risk of the air being dried out because you don't have built-in humidification here, right? Whether you have whatever kind of hole you have in your neck, whether it's trach or laryngectomy, if it's uncapped, it's open, the air is not moisturized and it can dry out. So you have to have a humidified trach collar. If you have a cap on there, door shut, you still have trach, but it's just shut and you're breathing through here and you have humidification, so that's fine. But when you're uncapped, you run the risk of the secretions being very dry because they're not humidified, because there's no built-in humidification. So then your secretions can get sticky and cause a plug and you can't breathe, things like that. But if a cap is on there, it's not an issue. A laryngectomy, you're not capping the laryngectomy because you have to breathe through that. So the biggest thing to know with a laryngectomy is, and an uncapped trach, is that you've got to humidify this air, right? The door's open, we got to humidify it. Door's always open on laryngectomy, door's open on the trach when the cap's on. So humidification is really important. They can be on room air, but we still want humidified air. They might have, 40% oxygen with humidified air, but they're weaned to room air, fine, but they still need room air, like humidified room air. Having a humidifier in the room at the bedside is not usually enough. When they're at home, they've got to have this dedicated way to get humidification here. So that's a big thing because plugs can happen very easily and can completely obstruct their airway. So there's a couple different ways to do humidification, and I'll get in a minute, but traditionally we're using the humidified trach collar that you're all used to seeing that you use with trachs and laryngectomies. There's also this HME device, which I'll talk about in a minute, but it's very important to provide this humidification and also frequent suctioning to avoid plugs, educating the patient and caregiver, you're breathing through here now, your nose is just for show, nothing, not gonna be useful here at all. You're only breathing through here. And then giving them emotional support and kind of helping them come up with like communication tools, because it'll take a while for us to work on voice things. When the patient comes in and has a laryngectomy, I always tell the patient, our goals are going to get you to eat and to talk, but we're not going to address those things while you're here in the hospital. Our goal in the hospital is have the surgery, get through surgery, get out of the hospital, finish recovering at home. And when you come into the clinic, that's when things are going to be healed up enough that we can start working on eating and talking. So, but that's on the top of their list, of course, but it's kind of at the bottom of ours. So kind of reassuring them, yes, I know you can't talk right now, we're going to get to that. Docs will kind of work on that, as you come back to the clinic, but let's think about different communication things. There's apps they can put on, like Passy Mirror company or website has like a free app that patients can use. And I've kind of given that to patients, but a lot of patients just kind of use a whiteboard or, paper, or they, like this and form letters because you can read that and understand that quick. There's always patients that are trying to spell stuff. And I'm like, don't waste your time, just write it down, or reading their lips, but kind of reassuring them and coming up with a way that they can communicate. Because it is, you think about how just vulnerable they are. You're in a hospital, you can't take care of yourself, and now you can't even express yourself. I mean, it's just, my heart just goes out to them. It's just, they're very, very vulnerable. So kind of having those different ways for them to communicate. Some people don't like to write, or their writing skills or reading skills are really bad. So the picture boards are really helpful. Picture of somebody going like, oh, I'm in pain, or something like that, or a picture of a toilet, things like that, are really helpful. So and then the bottom line here is, that the stoma is their only airway. So if they require, supplemental oxygen, obviously the humidified air is going to go here. Oxygen's also going to go here. And then if they, stop breathing and you had to do CPR, or let's say they're so oversedated, they're not initiating a breath, you would need to put either an endotracheal tube or a trach in, but the easiest thing would be doing an endotracheal tube that's cuffed, which most of them are. Pediatric ones I know are not cuffed, but a cuffed endotracheal tube into the stoma, inflate the cuff, and attach an ambu bag, because you're not going to be able to fit an ambu bag onto that Blom singer, or even if they didn't have a Blom singer, ambu bag is not going to hook onto anything. You need to hook onto something. A trach, it's really easy to hook an ambu bag on, but the laryngectomy tubes, you can't. So using an ET tube is the best thing to do for that. And that's what we do like in the OR. So like, let's say a patient comes in with a trach and now we're doing some surgery on them. Usually what we do is, because we're working in that area, after they're asleep, we'll take out the trach and put an armored ET tube in, which armored is like, it's got the little coils inside it. So we'll do those a lot. But for your intents and purposes, any cuffed endotracheal tube is what you're going to want to get because you're doing it, emergently. Okay, Blomsinger tube. So you've probably seen these little silicone tubes that are very squishy, and everybody calls them a trach, which I totally get it. When you're kind of looking at this from a distance and you only see it once or twice a year, it's natural to just want to call it a trach. And like I said, physicians do that. Everybody does that. So, but basically the purpose of this Blomsinger tube, that's the brand, the generic, it's a laryngectomy tube. So the purpose of it, it's silicone. It's not hard and fixed like a trach. And it comes in different sizes. There'll be a number, then a dash, and another set of numbers. The first set represents the diameter of the tube, and the second number represents the length. So typically we have 955s. Usually the 55 is usually consistent. We might change from like a 9 or a 10, but almost always 55. 36 is just way too short. So they do need to be cleaned. They get, blocked with secretions and such. And cleaning them, you can use a trach brush. You can also use the little swabs, the oral swabs with the sponge. Those work really well to clean those. If you don't have any of the little brushes, you can use soap and water. We usually tell patients, or in the hospital up on 4B, they'll use like half strength, hydrogen peroxide. You can also use saline. You don't want to, and we all know this, right? We don't use tissues or paper towels usually on anything because it's all clumpy, but something we always explain to the patients too. So using gauze is the best because there's no lint or debris that would clump and get into their airway. Typically, when your patients, when you get them into PACU, often you'll have this brand new laryngectomy and this Blomsinger tube, and there's no trach ties. And you're thinking, that's crazy because, you don't want to fly out. But if we're doing a free flap, which the majority of these laryngectomies are, typically we don't like the trach ties because it can cause compression to the free flap pedicle and such. So usually it's not an issue in the beginning. You might have someone that comes from the floor that had a laryngectomy while they're here and they're coming down to the OR for something and it, might fall out. So in those times you can ask, can we put trach ties on? Sometimes, we can, but it's something we have to ask about. So the big thing to remember is, if this is your neck and here's this laryngectomy and, it's sitting right here at the surface, the point of this Blomsinger tube is to support this new stoma as it heals. And oftentimes, the bulkiness of the flap of this patient, whether it's like an exposed flap or it's buried, I always tell them it's kind of like, my big double chin, it's right here. And if you have your trach here and, the bulkiness of it, this is going to occlude it. And especially if the patient leans forward and they're writing something or leans forward to do something, a lot of times it'll occlude. So if that tube falls out, they're not going to be able to breathe. And some of our patients, they've had super bulky, they have a short neck, and now it's all swollen. So there's just not a lot of room. And some patients, as soon as that Blomsinger comes out, they will occlude like right away. We've had a few of those. So, in that case, sometimes we've sutured the Blomsinger in place instead of like trach ties because it does affect the pedicle. But basically, the point of this Blomsinger is to just hold up that muscle or bulkiness or double chin, keep it from collapsing onto the airway. So it's not like a trach, like, if a trach tube fell out, we'd want to get that back in because there is no way, here's a trach just kind of hanging out in the wind, right? No tube to cannulate through there. Like, let's say whatever, they can't breathe up here and they can only breathe through their windpipe. If a trach comes out, that's a big deal. You got to get that back in. But a laryngectomy, it's here to the surface. So if the Blomsinger comes out, I mean, it's an issue, especially if, it's going to get obstructed by this flap. But if it's not, I mean, and it falls out, it's a issue. We want to get it back in, but it's not like a trach came out. Do you know what I'm saying? So it's hard to differentiate them, especially if you don't see them very often. But basically, that's the point of that Blomsinger tube. It's there to support the larynx as it's healing, and most often is to help keep the muscle, anything above that larynx from collapsing on itself. So I always tell patients too, if all of a sudden you're like, oh my God, I can't breathe, the first thing I want you to do is just kind of lift your head up like this, not like this, because it would start your incisions and stuff, but just kind of neutral position, straight up, and okay, it was just my flap covering it because I was bent over writing or something. And then, like I said, if the Blomsinger came out, you'd want to put that back in. You're not usually going to false passage it. Like a trach is tricky. You're not a trach. If the trach fell out, you're going to put it back in using the obturator. The driver is what I call it, because it's kind of like, think about a pen. If this is the trach and this here is the obturator, it protrudes out a little bit. So trach, you would be able to put it in and you'd reduce the risk. If you didn't use the obturator, you just kind of put it in, you run the risk of, without this guide here, you run the risk of false passage, right? Where it's not getting in. And you're like, oh, it looks like it's in, it's nice flush with the skin, but an issue. So anyway, the trach, you want the obturator to go in. That's why it's always above the head of the bed. With the Blomsinger, the airway's already there. It's just, you might have to lift up this skin, lift up this bulky flap, get it in there, right? But, you don't need an obturator for it. Most of our patients, we want them wearing this Blomsinger tube, continuously for a few months after surgery. Some patients, they run the risk of developing stenosis here. Then they have to come in for dilations. You might have seen like a lot of these little outpatient things where you're doing, stomal dilations, and that's because they've stenosed down. So that's why we want them to keep that tube in. Okay, so humidification options, and you might have seen these as well. So previously, am I doing okay on time? Sorry, because I know I talk a lot. I gotta hurry up.
We'll have to wrap it up in like 5 minutes.
Okay, I can be quick. So 2 options with humidification for a laryngostome. So trach, the only option is a humidified trach collar if it's uncapped. But laryngostome, you can use a humidified trach collar, which is great. It's easy, but it's a pain in the butt. You got to carry with it to the bathroom, and going home, and the dog's chewing on the tubing, all these crazy things. So humidified trach collar is good, but can be cumbersome. So recently, this kind of came up with COVID too, is using these humidified moisture exchange to discs, or HME. So basically it's like a little, looks like a wafer, and it fits on the end of the Blomsinger tube. And when a person inhales, it kind of retains the heat and moisture and carries that with the air to the lungs. So it's a way to humidify and moisturize the air as the patient breathes, as it goes into the lungs. So it's much easier, not bulky, to use instead of a trach collar. And in fact, I thought they were not as effective. I always thought the gold standard was a trach collar, and we're only using HMEs because of COVID or something. But it actually is just as effective as the trach collar. So our SLP, inpatient SLP, she works with all of our patients post-op laryngectomy. And if they can get it on and off themselves, independently, then we use it. The times that you can't use it is if the secretions are super thick and tenacious, and then they plug the filtering capabilities of this HME, then you got to use the humidified trach collar. You want to replace it once a day. So we always tell patients, if they can tolerate wearing the HME, the secretions aren't too thick, they can handle putting it on and off, they understand it, we use it. But we always have them have humidified trach collar set up at home in case they run out of the HMEs, or the secretions are so thick they can't use the HMEs. Usually it's because they run out of them, but always have the collar as a backup. But they can just do the HME. If the HME works good enough, then that's great. And they much prefer it. So you might see those when they come down to the OR, and you probably have to take them off, but you can put it in with their belongings, they can put it back on, things like that. All right, so speech. There's a lot of different options for speech after laryngectomy. Again, it's not addressed till they come back for the clinic visits, so we're not addressing it inpatient, but using electrolarynx, which you may have seen over the years, your grandparents had them, kind of thing. So those work well. We have used those, but people don't like them. Esophageal speech, which we don't do that often. It's kind of odd, but kind of moving air from your stomach and kind of controlling it. It sounds like something a bunch of little, grade school boys would love, because you're burping and things like that. Sounds like something fun for them, but I don't know. I don't think I'd go for that one. You know what I mean? Like, boys they burp and they giggle and they just think it's so funny. Yeah, so that's that. But the one we most, oh Oh, really? Oh, that's funny. Oh, that's funny. Oh, that's funny. So the most common thing that we do is this TEP, and you might have seen this done in the OR. We often do it in the clinic, but sometimes we have to do it in the OR. And basically, you're doing this puncture. It's, here's your trachea, here's your esophagus, and basically, if this is your trachea, you're going in, you're making it, and you're poking a hole in here. So it kind of goes through the trachea into the esophagus, and it's like a one-way valve, and it allows air from the esophagus, or air from the trachea to go up through your esophagus and get your speech. So it's pretty neat, and you can see it in a patient if you're looking down into their airway or larynx. You'll just see like a little, it looks like a little clear or white little dot, like almost like a snap from your jacket or something, like those little circles. That's what it looks like, and it'll have like a little tail on it sometimes that they'll tape up on the outside of the skin. But that's what that is. They do get clogged. People have to rinse them. Sometimes you get some skin breakdown. There's lots of ways they have to maintain it. The patient's not really compliant with things. A lot of times they come in with people leaking and all sorts of issues. But that's what we do. But the bottom line is, for you, there's not really anything really to do. If you see one in there, it's like, oh, they got a TEP. You don't think they just inhaled some paper clip that was up on the floor or something. But if you see something that looks like a little white clip, that's what that is. But always kind of double check with people. But basically that's what they'll do for that. And again, we don't do that until they're out of the hospital and recovered from the initial surgery. They change them every couple months. There can be issues with them, but for the most part, they're good. So yeah, the big takeaways are laryngectomy is permanent. The only way you're breathing is through your neck. So putting oxygen here is not going to help. You have to always humidify laryngectomies. You have to humidify a trach if it's uncapped. We can restore their speech and swallow functions. That's almost always we're able to do that with our patients, but we're not going to start those things until like the postoperative period. And that's about it. Kind of in making sure, like, kind of checking that airflow. If you're feeling air, exhale the airway, from the trach or from the laryngectomy. That's a good way to reassure that you're in the right spot with the trach. Or if you can pass the suction catheter without difficulty, then your trach's in the right spot. Yeah, that's about it. Sorry, I know it was a little quick and I kind of jumped to the end, but references are here. And that's about it. Oh, yeah, sure.
I had a patient that was talking out his lungs. How worrisome is that?
Yeah.
Like literally it is constantly coughing. Flying out.
Yeah.
Where it's
Yeah.
like they cough.
You just put it back in, like,
Right.
yeah,
Yeah, it's on the floor, it rolls under the
Yeah.
bed. Yeah, right. Yeah. Yeah. Right. Well, I mean, you can ask if you can do trach ties and they might say no, sometimes what I've done is put like a little piece of gauze here to kind of anchor it, or, other kind of different things, like almost putting trach ties on, but instead of it going like this, like loop it through the little holes and then like taping it to the chest, Yeah, there's little, yeah, they are on there. They're just clear. They're hard to see.
Okay.
Let's see. Oh, wait, go this way.
I was listening.
No, I know, I got you. Yeah, you can't really see it, but well, you can hear it. So this is the old-fashioned. See that little slip there?
Oh, yeah.
It's not a good picture.
Yeah, I know, I've never noticed.
Yeah, there's a little person there, you can't really see it, with the little thing there. You don't want to make it really tight and stuff, because it's silicone, it'll rip. You gotta really- Here. Okay, this one you can't put H&E on. You still see them. These are the ones you like, how big and juicy this one is. There was a good. But yeah, they all of them, both of them have a way to attach.
I like that if you could even get it through there.
Yeah, I call it the Molly way.
And maybe you talked about it. I was listening.
No,
I
it's
didn't hear it.
okay.
We used to like lobby, right? Sort of like in the right building.
Aaron Chapin. Because,
Okay.
yeah.
For the trach or the laryngectomy?
Both.
Yeah, so like,
For either, can you
Yeah.
do it for either one?
yeah, so normally I was telling people this too, because like I was in
I see
ICU for a
Aaron's
long
on here.
time before I came here, and someone who's had a trach forever, they're trach dependent, they're on the vent, like one of those kind of people. It's an established trach, so you only want to suction half tube, suction trauma and all that
Yeah.
stuff, like CCRN put on all that crap years ago.
Yeah.